So today's lecture is going to be about hemodynamic disorders and thromboembolism. When discussing hemodynamic disorders, the key organ system you need to understand is the blood and the vasculature. So blood is an essential tissue necessary for transport of oxygen and nutrients as well as waste products. We know that blood is actually the transport medium in which essential nutrients, oxygen, white blood cells, red blood cells, various other important substances needed for cellular function are actually carried. And because of the nature of this tissue, so to speak, we know that it can also be affected by various physiological changes which may actually make it more fluid or more viscid, resulting in these hemodynamic disorders. So several disorders exist that could impair this function. However, to understand the abnormal manifestations of functions, it's essential to have an understanding of the normal physiology. So we have to understand the composition of blood, and we know that blood is composed of whole blood in totality, and this can be split into plasma and formed elements. 55% of blood is plasma, and the remaining 45 are formed elements. The formed elements mainly consist of leukocytes, platelets, and erythrocytes being the more dominant of the cell lines at 99%. The plasma is 91% water, 8% protein, and 1% other substances. So these are mainly dissolved substances, ions, and other essential substances required. Apart from that, there are essential terminologies you need to understand. Of these, we have edema, hemostasis, hemorrhage, thromboembolism. So edema is basically the accumulation of fluid resulting from a net outward movement of water into extravascular spaces. It's the result of the movement of fluid from the vasculature into the interstitial spaces. So we're talking about movement of fluid from the blood vessels to the tissue. And it's for this reason why the fluid that is found in edema is often referred to as tissue fluid. So this fluid may be protein poor, which is a transudate, or it may be protein rich, which is an exudate. Hemostasis is the process by which blood clots are formed, and it's a way in which the body actually tries to prevent excessive loss of blood as a result of blood vessel damage. So hemorrhage itself is the escape of blood from a ruptured vessel, and it may be internal or external. Thrombosis, on the other hand, is formation of a thrombus. So a thrombus is more or less a clot. You find that thrombosis can be formed as a result of the activation of the clotting cascade, but it may also be pathologically invoked as a result of various factors. Embolism is obstruction of blood vessels by foreign substances, and thromboembolism is the formation in a blood vessel of a clot or a thrombus that breaks loose and is carried by the bloodstream to plug another vessel. So these definitions are very important for you to understand in terms of the lexicon of hemodynamic disorders, and it will make it more easier for you to actually interact with your colleagues in the clinical spheres. So let's get a better appreciation of edema. So edema can be localized, such as in the plasma, or it can actually be generalized, anasaka. This is where you have edema in all parts of the body, several parts of the body. Edema is mainly due to two forces. That's an increase in intravascular hydrostatic pressure or a reduction in osmotic pressure provided by plasma proteins. So we know that the intravascular hydrostatic pressure is a function of the systolic blood pressure. So with a high pressure, we know that high pressure would force fluid through the spaces or the pores in between cells. The higher the pressure, the more fluid that will be forced into the interstitial spaces. That's why you find in conditions associated with elevated pressure or hypertension, you'll find that there'll be accumulation of fluid in the tissue spaces coming from the blood vessel. So we're talking about things like pulmonary edema being a very prominent example coming to mind. The other factor is reduced osmotic pressure provided by plasma proteins, or what we usually call as the oncotic pressure. So the oncotic pressure is a pressure that is exerted by proteins in circulation, and this pressure actually directs the flow of fluid into and out of the tissue space into the vasculature. So depending on the oncotic pressure, we're able to actually find out, we're able to determine whether or not fluid will accumulate in the interstitial space or will remain in circulation. So as when you have a loss in the oncotic pressure as a result especially of loss of proteins, you find that this reduces the oncotic pressure, and the reduction in the oncotic pressure means it can no longer facilitate the water to remain in the vasculature, resulting in the fluid within the vasculature to be forced into the interstitial space because of movement across a pressure gradient. Some of the typical causes of edema include increased hydrostatic pressure as a result of impaired venous return, congestive heart failure, constrictive pericarditis, ascites, venous obstruction or compression such as in Budd-Chiari syndrome, thrombosis, external pressure such as in tumors. Then you also have lower extremity inactivity. For example, when you're having an operation and you are bedridden for quite a long time, or you have a chronic illness, also associated with prolonged dependency. Arteriolar dilatation may also cause edema. This is as a result of heat, neurohormonal dysregulation. Reduced plasma oncotic pressure, as discussed earlier, can be as a result of hypoproteinemia or loss of protein in serum. So these can be caused by protein-losing glomerulopathies, such as nephrotic syndrome. They may be associated with liver cirrhosis, which commonly presents as ascites. Can also be as a result of malnutrition or protein-losing gastroenteropathies. So in these conditions, you find that someone actually loses protein in stool. You lose protein in stool, and with malnutrition, that's where the intake of protein is actually too low, lower than the recommended daily requirements, resulting in a reduction in total protein, and especially albumin being a very important protein in the body. Lymphatic obstruction may be as a result of inflammatory, neoplastic, post-surgical, or post-irradiation. Sodium retention is also a known cause of edema, and excessive salt intake with renal insufficiency and increased tubular reabsorption of sodium being the main culprits. Inflammation is also a cause, as we learned earlier. So acute and chronic inflammation may cause edema as well as angiogenesis. So some of the thromboembolic events we have to understand, which have a clinical significance, include ischemia and infarctions. So ischemia is as a result of lack of oxygen due to impaired blood. Ischemia causes a lack of oxygen due to impaired blood supply. So you find the vasculature is occluded by this thrombus, and because of that, there will be downstream injury resulting in necrosis. So as we learned earlier, ischemia can also be associated with a reperfusion injury if circulation is restored. We also have an infarction, and an infarction is tissue necrosis due to ischemia. And the major causes of morbidity and mortality, especially in the developed world, are myocardial infarctions, strokes, and pulmonary embolism, which are known thrombotic events. So all these will be associated with infarction. So in myocardial infarction, commonly colloquially referred to as a heart attack, you'll find there will be infarction of the myocardial cells, the myocardial tissue, resulting in impaired contractility and reduction in the capacity of the heart to actually pump blood effectively, resulting in heart failure. We also have stroke, which is an embolic phenomenon, thromboembolic phenomenon in the brain. So basically you can understand it as a cerebral infarction. Pulmonary embolism can also lead to a pulmonary infarction because of occlusion of pulmonary circulation. We also have hyperemia and congestion. Hyperemia is an active process resulting from arteriolar dilatation and increased blood inflow, as occurs at sites of inflammation or exercising skeletal muscle, resulting in an increase in blood volume. So when you have hyperemia, you usually have a reddish tinge which will be associated with the tissue that is hyperemic, and this is because of an increase in the amount of blood that is going to that particular tissue due to some physiological or pathological stress resulting in this hyperemia. Congestion, on the other hand, is a passive accumulation of blood as a result of impaired outflow of venous blood. So hemostasis, as earlier mentioned, is actually the formation of a clot. Normal hemostasis comprises a series of regulated processes that maintain blood in a fluid clot-free state in normal vessels while rapidly forming a localized hemostatic plug at the site of the vascular injury. The pathologic hemostasis is thrombosis, the formation of blood clots within intact vessels. Both hemostasis and thrombosis involve three elements: the vascular wall, platelets, and the coagulation cascade. So as we know, there's a constant internal environment trying to maintain the blood in a fluid clot-free state. We have two counteracting forces, which are the procoagulant factors and the anticoagulant and antifibrinolytic and the fibrinolytic factors, and these are actually trying to balance out to ensure that the blood is maintained in a fluid state and allowed to conduct its transport function. When we have an alteration in this towards the procoagulating factors, we have a state of thrombosis leading to the formation of blood clots in these closed vessels. And it's important to understand that these three elements are very important in hemostasis and thrombosis. Normal clotting involves the initial vasoconstriction followed by primary hemostasis mediated by the platelets, followed by secondary hemostasis mediated by the clotting cascade. Eventually, this leads to the formation of an insoluble clot. So we won't go into detail with the coagulation cascade, but it's important to understand that there are two main pathways which join at the activation of factor 10. So that's the intrinsic pathway and the extrinsic pathway combining at the common pathway. So what are the counter-regulatory mechanisms that help to prevent hemostasis or clot formation? So one, we have the fibrinolytic pathway, which is mediated by urokinase-like plasminogen activator and tissue type plasminogen activator. We also have the anticoagulant pathways, which is mediated by antithrombin 3, protein S, and protein C. So this is very important to understand because these two pathways are working to try and prevent abnormal clot formation. These are actually derived from the endothelium and from factors produced in the liver. So the endothelium also plays a very important role in coagulation and anticoagulation. So it somehow has a balance in between the two to maintain the blood in its fluid form. So the antithrombotic functions are targeted at the platelets, at coagulation, and fibrinolysis. So the antiplatelet function of the endothelium is associated with reduction in the amount of adenosine diphosphatase. As we know, ADP is very important in the clotting cascade. Prostacyclin and nitric oxide are found within the endothelium and they stimulate vasodilatation. Anticoagulants. Anticoagulants are found in the endothelium. These include heparin-like molecules which activate antithrombin 3, thrombomodulin which activates protein C, as well as protein S synthesis. The fibrinolytic functions include the production of tissue-type plasminogen activator. The procoagulant functions, on the other hand, include the production of von Willebrand factor, production of tissue factor, and binding of factors 9A and 10A. So we know Virchow as the father of modern pathology, and he has given his name to this very important triad in hemodynamic disorders. So this triad, the Virchow's triad, denotes some of the factors associated in thrombosis. So these are endothelial injury, abnormal blood flow, and hypercoagulability. Endothelial injury exposes procoagulant subendothelial extracellular matrix. So we have those procoagulants such as ADP, calcium, being exposed and setting up a chain of reactions resulting in coagulation. Commonly found in the heart, atherosclerotic plaques, and areas of vasculitis. So endothelial injury also sets up for other aspects of the Virchow's triad. So it's more or less having a summative effect to bring about this coagulation. The next factor is stasis. So alterations in blood flow is stasis, and this alteration mainly refers to the slowing of blood flow. Under normal laminar blood flow, platelets and procoagulants tend to be in the central region of vessels. However, in stasis, they tend to be pushed to the peripheries closer to endothelial walls. Turbulence may also have the same effect. Both promote endothelial cell activation and enhance procoagulant activity in part through flow-induced changes in endothelial gene expression. Stasis allows platelets and leukocytes to come into contact with the endothelium when the flow is sluggish. Stasis also slows the washout of activated clotting factors and impedes the inflow of clotting factor inhibitors. So you can see how you're having this knock-on effect from different aspects of the Virchow's triad working together to actually bring about coagulation. So you can see with stasis is further enhanced by endothelial injury. With the stasis, you have the platelets and the white blood cells being closer to the endothelium than they're supposed to be. And if the endothelium is damaged, because of the exposure of those procoagulant substances in the endocellular matrix, extracellular matrix, you have activation of the platelets and the white blood cells to facilitate for this coagulation. The final factor is hypercoagulability. So this is defined as any alteration of the coagulation pathway that predisposes affected persons to thrombosis. This can either be genetic or acquired, and it's more common a cause of venous thromboembolism than arterial embolism. So under genetic, we know that there are certain mutations, especially in the European population, that can result in hypercoagulability, such as Leiden 5 mutation. You can even have homocystinemia as well, being a genetic cause. Some of the acquired reasons may be as a result of neoplasms, most especially cancers. So embolism, we'll talk a bit more about embolism. An embolus is an intravascular solid, liquid, or gaseous mass that is carried by the blood to a site distant from the point of origin. So it can be as a result of any substance in the blood that can cause a blockage can be referred to as an embolus. The vast majority of emboli derive from a dislodged thrombus, hence the term thromboembolism. Types of emboli include fat droplets, bubbles of air or nitrogen, atherosclerotic debris, cholesterol emboli, tumor fragments, bits of bone marrow, and amniotic fluid, which is very, very rare. Inevitably, emboli lodge in vessels too small to permit further passage, resulting in partial or complete vascular occlusion. The primary consequence of systemic embolization is ischemic necrosis or infarction of downstream tissue, while embolization in the pulmonary circulation leads to hypoxia, hypotension, and right-sided heart failure. So here's an example of a pulmonary thromboembolism. So this is actually a saddle embolus in the branching main pulmonary artery. So we know that the majority of pulmonary thromboembolisms are as a result of deep venous thrombosis in the lower extremities. So because of a dislodged thrombus at that site in the lower extremities, this travels through the vasculature all the way up into the pulmonary circulation, where it occludes at the site of a possible change in the flow of blood. So we know that at the branching of the main pulmonary artery, there's definitely room for alterations in the blood flow, resulting in stasis and lodging of a thrombus. We also have systemic thromboembolisms. So here we're seeing a white infarct in a solid organ such as a kidney. This is a renal infarct secondary to systemic thromboembolism. So the majority of systemic thromboembolism arise from the heart, so they are cardiac in origin, usually as a result of a mural thrombus there. They may be associated with cardiovascular vegetations, valvular vegetations to be specific, and also aortic aneurysms. So this is the list of references you can go through to get a better understanding. Thank you so much.